The following presentation is not intended to replace the advice of a physician or medical specialist. For medical advice, please consult your doctor or a medical professional regarding any potential diagnosis or disease management concerns you may have. This material is intended for manual therapy practitioners who are interested in viewing information on the role and complexity of the lymphovascular terrain. Welcome to Part 4, Mediastinal Lympho vascular terrain. My name is Ivan Dubin. I'm an osteopathic practitioner based out of Vancouver, British Columbia. The educational goals of this presentation: it's a continuation of the cranial and cervical lymphovascular terrain as it descends into the mediastinum, and it will include aspects of the diaphragm. The diaphragm will also be covered in Part 5, the liver, and Part 6, stomach and epigastric area, because it's such a critical component to the lymphovascular system. The structures and contents of the mediastinum are presented with the underlying vascular tree architecture as it contributes to the pressure gradient dynamics. So these are all things that I've covered in previous presentations. In addition, we can consider the addition of the central chain by Canadian osteopath and Professor Philippe Drouel as a tensegrity structure that is providing the support for the vascular tree. Prior considerations of the cranial and cervical lymphovascular terrain provides a safe therapeutic access point for liberating aspects of the central nervous system that would otherwise limit viability of the mediastinum. What this means is treating the cranial base will allow for liberation of a vagal nerve response, bringing balance between the parasympathetic and sympathetic, also opening up the circulation into the cranial base, ensuring that the fascial sheaths around the carotid arteries are also free. This will make it easier to assess the mediastinum, such as through inhibition, looking at the pericardium and heart. So as a precaution, it's a good idea to liberate the brainstem before applying any direct techniques in the mediastinum. Now, that's a generalization, but it is something for your consideration. The Part 4 overview of topics. Consistent with previous presentations, we're going to do a quick review of what is lymphovascular terrain. Then we'll talk about typical lymphokinesis physiology, and we'll look at a mediastinal lymphovascular terrain overview. We'll also discuss some pressure gradient dynamics. We will then dive in and look at the heart, the lungs, the esophagus, the diaphragm, the thoracic duct, and then at the end we'll look at clinical applications. So as we're moving down from the cervical and cranial lymphovascular terrain, we're going to follow the lymphatics down into the mediastinum or chest cavity and its associations with all of these structures and organs, keeping in mind again that we are anatomically moving from head to toe, but that the lymph in fact does not necessarily move in exactly that paradigm, even though there is lymph that moves down to the mediastinum, which I presented in the cranial cervical lymphovascular terrain. What is lymphovascular terrain? All connective tissues and all fluids that contribute to the living human being, otherwise known as the living bioplasm. That's includes a microbiome and in particular the epithelial lymphatic cells. The terrain is a result of interrelationships of the lymphatics, all connective tissues, including the nervous system and all vascular structures coexisting in one ecosystem. That also includes the mucosal barriers. Ultimately, the terrain of the body is contained within a pressurized living metabolic sponge of varying tissue tensecrities, tissue densities, chemical properties, and electromagnetic properties. This image is you've seen before, just again reminding us of the interrelationships between the tissue cells, the veins, the arteries, the blood capillaries, and the interstitial fluid. Now, what's not included in this particular diagram is the nervous system or the mucosal barriers and the microbiome aspects, and obviously the blood, since it is also considered a connective tissue. But what we want to just take into consideration is the potential for the tensegrity dynamics and pressure gradient dynamics in amongst all of these interrelationships. This image is just capturing the epidermis and dermis layers below the skin, showing us the proximity of the lymphatics with the vascular system, the elastic collagen fibers, and the interstitial matrix that is the fluid. And so in this regard, the fluid would be inclusive surrounding. And we do know now that the interstitium itself, which is also this contained within this dynamic, has also been considered an organ. Here we have another subdermal rendition of lymphovascular terrain. This is just your veins, arteries, and lymphatic structures, and just note how they get smaller as they go towards the superficial layers of the dermis, and they get deeper as they go towards the center of the body. And we'll be looking in more detail as we're following through, including the deep lymphatic system of the mediastinum. This image allows us to appreciate the organization of the lymphatic system as it moves from superficial layers to deep layers. Here we've got, you can see in through the muscle, traveling down to the artery and the veins. You can see how the lymph is pushing down in and extends into different aspects of the muscle. This is consistent throughout the whole body, even though this is just a cross section. And again here, we can see how the artery is supported by lymphatic structures, giving rise to the notion of the deeper lymphatics that are typically not viewed in the classic superficial lymphatic lymph node diagrams that we'll see in anatomy texts. It's also important to note that the lymphatic vessels do in fact go all the way directly into the bones. And in the case of injury or stress, you can see an increase in lymphatic vessels listed here in purple in terms of the healing process after there's an injury. Looking at the individual lymph nodes, what's critical to appreciate in this dynamic is that even though you have lymph coming in and lymph coming out of the lymph node, you also have blood vessels that are supplying each individual lymph node. Now, because blood is coming in and blood is coming out, that's an additional immune-related function, detoxification, that's being provided to each individual lymph node. So the toxicity, toxic proteins, leftover debris is is not just moving through the lymph through the chain of lymph nodes, but each lymph node is getting supported by the vascular system. So you can see how a lymph node might run into trouble if there are any forces that are limiting the movement of blood in and out of a lymph node, or the movement of lymph in or out of the lymph node, which is why I believe there are so many connections. Each lymph node is roughly connected to at least 2 or 3 other lymph nodes. There are a few that are solitary, so to speak. They're at the end of a chain. But the chain allows for each lymph node to be supported by its neighboring lymph nodes. And I suspect that when there is a situation where the entire lymph node is overwhelmed, you might see the establishment of a cyst to try and somehow assist the physiology or limit exposure to other lymph nodes. Not certain on that. It's a theory, but it is interesting to question, why does a cyst actually occur in and around, mostly around a lymph node. Looking at superficial lymph nodes, here again is that example I was talking about of lymph drainage, how it's moving from one node to another. And obviously here you've got the nodes, and these are still lymphatic structures here, known as territories, and they're designed to superficially assist moving lymph in the superficial layers. You can see the direction of lymph will vary depending on its lymph node, and obviously I'll discuss the general lymphokinesis physiology and how the lymph is designed to move in the body. This is just isolating a group of superficial lymph nodes. We don't know exactly where this is located in the body, but it's just being used as a reference. This image allows us to see the lymphovascular terrain within the microvilli. So we have the microvilli here. Here we've got the inside that we're looking at. So you can see the interchange between the arterial system, the venous system, and the lymphatics, how they're intertwined. You also, in this image, we have the nervous system included as well, which is obviously in yellow. And then when you see these small little dots, these are still components. They're lymphoid follicles, lymphoid tissue follicles, assisting in the detoxification and absorption capacity that each microvilli possesses. Now we have millions of these inside our intestine, and you can see how intimately they are connected to the lymphatics. And of course, the outer layers of the small intestine, you can see how they're represented down here. And these are the vessels, lymphatic vessels start to get a bit larger. And these crypts of Labracun are also areas here where you will have beneficial bacterial colonies, or hopefully they're beneficial, but the microbiome does tend to hang around in some of these crypts. And we also have to consider that the outside of these microvilli have a mucosal layer as well, and that is part of the immune system. As I've mentioned, additional components of terrain, we have MALT, the mucosal associated lymphoid tissue. This includes the entire ear, nose, throat passageways, respiratory tract, digestive tract, and reproductive tract. Basically anything that has a tube will have a mucosal associated lymphoid tissue. Just changes its name as it travels through the body. All endothelial and epithelial line structures have one or more mucosal layers forming an immune barrier. The microbiome and bacterial environment is embedded in various mucosal layers and is proving to be a critical factor in the dynamics of health within the terrain. Optimal terrain function also exhibits the aspects of the structured water phenomenon. This is coming from Seffinger in 2018. Now, I'm not going to go into high detail about the structured water phenomena. I'll let you do that if you want to look into that. Dr. Cowan is someone that's done a deep dive on that. What is the mucosal layer? Mucosal layer contains mucin. It's a major barrier to infection. Mucosal layer serves as a type of barrier between the outside world and the host. It's composed of rapidly replicating arrays of epithelial cells. The sensing of the external environment can occur via the extensive nervous innervations, since the cells are avascular in nature. Mucosa provides microbial, biochemical, mechanical, and anatomical barriers to prevent infections. Recent studies on mucosa. The mucosal layer not only acts as an important factor for protecting the host against microbial invaders, but also contributes to the mutualism between the host and the microbes. Many diseases are associated with the alteration of the mucous layer thickness, but it is still difficult to identify whether this effect is a cause or a consequence of the disease. Additionally, recent evidence suggests that specific gut microbes contribute to the regulation of the mucous barrier and eventually intestinal and host health. There's also some indications that the mucin feeds off a very specific type of beneficial bacteria in your body. So in the cases of leaky gut, it could be something that's occurring where you're losing the mucosal barrier, and if you don't have the proper microbiome bacteria, communal bacteria present, then that can lead to degeneration. Moving on to talk about the typical lymphokinesis physiology. The lymphokinesis meaning the movement of lymph through the body. According to Foldy, the lymphatic system runs parallel to the arterial and venous system. Some characteristics of the lymphatic system are as follows. It begins in the periphery with initial lymph vessels. Along the way, the path of the collectors are interrupted by intervening lymph nodes. The flow of collector trunks goes into the venous system. The terminal site is a confluence situated at the left and right venous angles. I'm going to provide a diagram in a moment giving a general idea of the anatomy, physiology relative to anatomy of the lymphatics. In terms of the role of the lymphatics, it can be seen as an integrator of all bodily fluids and as the second circulatory system. If the lymphatic system would cease to function, the result would be massive edema, retention of toxic metabolic wastes, and death within 24 hours of onset. Now, I am also suspecting that the presence of any kind of non-injury related edema is giving an indication that there's a type of lymphostasis occurring locally or regionally, and that is something that in terms of looking at edema as a potential osteopathic lesion, I've discussed that already in previous presentations. And of course, we have to consider also that the lymphostasis can be hidden, meaning that it could be deeper, not just subcutaneous, but it could be in the form of hidden inflammation, which is also something I covered in the second presentation on the dynamics of health. On the topic of lymph flow or lymphokinesis in general in the body, the majority of flow of lymph moves back towards the heart via the venous angles under ideal or optimal pressure gradient dynamics. The flow of lymph must travel against any deep and superficial tissue resistance that surrounds the arteries, veins, and nerves. There is no central pump of the lymphatics. Rather, The flow relies on our ability to move our body and on ideal tissue pressure gradients when moving less. Exceptions to lymphatic flow occur around the liver, as it acts more like a lymphatic hub, moving lymph in multiple directions. This is also the case with the flow of lymph inside the mediastinal area, which moves lymph away from and towards the venous angles, moving from deep to superficial and superficial to deep lymph nodes. So I'm going to cover more of the complexity of how the lymph, in what direction the lymph is moving, to try and adjust. It's a different scenario. Pressure gradients change when we're still. Basal heart rate laying down at night is very different than when we're actively moving or even exercising. And when tissue pressure gradients in the mediastinum are too high, so if there's too much cardiovascular activity, then you're not going to get as much lymph moving directly in and around the heart as you would at a slower heart rate, because the pressure pushes the lymph into other areas. It doesn't mean you're not getting any lymph flow. It just you're going to get a distinction that is based on whatever activity level you're doing, and so we'll cover a little bit of that coming up. In order to attain optimal global lymphokinesis, the body requires certain parameters. We require ideal pressure gradients around the arteries in general. Excessive pressure around the venous angles will limit lymph flow. Excessive pressure in the mediastinum will limit lymph flow. Excessive upper cervical or pleural dome tension will limit lymph flow. Excessive tone in the diaphragm will limit lymph flow, especially at the entrance to the thoracic duct near the cisterna chyli. Also, suboptimal liver function will limit lymph flow because it acts as a hub. And the next presentation gets some more detail specifically on the liver. Also, suboptimal intestinal function will limit lymph flow. So adhesions and contractions, leaky gut issues, degenerative issues in the small intestine, mostly due to the fact that there's approximately 40% of our lymphatic system is in the gut, in and around the small intestine area. We'll touch on that in following presentations. And obviously scars from surgeries can also limit lymph flow, especially if somebody's had cancer of a lymph node and they're removing lymph nodes in an area, then that's going to obviously affect the possibilities of lymphokinesis in the area. Bruno Schickli on lymphatics. He says, we know that the lymphatic system recovers most of the fluid that escapes from the blood circulation. At some point, though, scientists thought that 90% to 98% of this fluid was recovered by the veins through blood reabsorption, and only 2 to 10% by the lymphatics. Situation is now inverted, and venous circulation may have an extremely limited role in reabsorption. In other words, most of the fluid that is leaked from the blood circulation into the tissues is regained by the lymphatics. The extracellular fluid is extraordinarily important for physiologists and body workers. In terms of any pre-existing rhythms contributing to lymphokinesis, within the context of pressure gradients, there's a potential for the rhythmic flow of lymph. Schickli defines two lymphatic rhythms that contribute to the passage of lymph. One is a rhythm of the pre-lymphatic connective tissue, and the other is lymphangions and lymph capillaries. The lymphangions act like a little heart, so they have a little pulse to them, and they can help move lymph along. And again, here, this reference to pre-lymphatic connective tissue really feeds into the theory that especially going back to the embryological distinctions where the connective tissue is present creating a lattice before the vascular system, and from that moment forward, the connective tissue, or the intelligence in the connective tissue, is organizing on behalf of the vascular system. And I believe that that's part of what he's discussing here. Is the body is intuitively trying to ensure that this movement is happening. Now, it could just be because the lymphatic, pre-lymphatic, and many of the lymphatic structures are near arteries, so I suspect that the connective tissue motion is happening first on behalf of the artery, and as a result, you have the other side of that where you have a motion, the same connective tissue motion is supporting the movement of lymphokinesis. The lymphatic system has the built-in function of using contractions in almost the entire network, and its goal to continue a steady rate of flow, and that's mostly utilized when we are moving. However, when we are not moving, that's where we can run into problems. This includes the ducts, lymphatic trunks, lymphatic collectors, lymphatic valves, and the thoracic duct itself. The thoracic duct I'll cover in this presentation as well, and it has a capacity to expand and contract. The constant expansion and contraction phase of lymph flow has the goal of propelling the lymph back toward the heart. And from Seffinger, the rhythmic contractions occur at a rate of 5 to 8 per minute at rest, but may increase with exercise and direct stimulation. It is possible to palpate these contractions. Now, again, it's interesting, this 5 to 8 per minute at rest. I find it interesting that there is the theory of the cranial rhythm movement that practitioners are taught to feel. And this feeds into my theory that, not just my theory, but the theory that the cranial motions or any intrinsic biological motion that could be palpated at anywhere in the body is driven by the connective tissue system on behalf of the vascular system. So you start to notice that these numbers are, this 5 to 8 would coincide with some of the cranial rhythm observations. Moving on with the topic of lymphokinesis, I think the best way to understand the lymphatic system is by really having an appreciation for the vascular tree. This is coming from Millard. A tolerably correct pictorial idea of the entire vascular system may be formed by considering the blood vascular part as made up of a great tree, the heart forming a short trunk, and the arteries, veins, and capillaries as the branches. But there is at present the untree-like character of the direct union of the terminal twigs of the arteries and veins. That is, the venous and arterial capillaries are continuous. The lymphatic system may then be represented by two vines of unequal size, but which together flow all the blood vessels to their ultimate manifestations, and in many places even send minute twigs beyond them. The analogy with the vine is further borne out by the lymphatic vessels, as they remain of a more uniform diameter than the blood vessels, and finally the slight expansion like leaves, thus forming a marked contrast with the terminal twigs of arteries and veins, which cannot properly be said to terminate at all. In a word, the blood vascular system forms a complete circle or circuit, while the lymph vascular system joins the blood vascular system at its central or trunk end, but ends blindly at the periphery. Looking at the vascular tree as an image, we can certainly add in the diaphragm. This will create the distinction between the negative pressure above the diaphragm and positive pressure below the diaphragm. Now, this mediastinal area is the focus for today's presentation. And why it's critical in many ways is because of the movement of the lymphatic system. Now, what we know is that the lymphatic system, like Millard says, winds its way in and around arteries and veins, making its way back towards more or less center, where we have the thoracic duct, then coming up, branching off into the left and right venous angles. Along the way, we have deep and superficial lymphatics moving towards from the periphery back to the center. This is coming from all the extremities. We also have the glymphatic system, lymphatic network, connecting to the lymphatic system of the cranial and cervical area, also inclusive of deep and superficial lymphatics and lymph nodes that are moving down towards the venous angles as well. Now, the next presentation, when we discuss the liver as a hub for the lymphatic system, it will bring into question some of the movement of lymph in and around the liver, suggesting that in this particular theory, the lymph is moving from periphery to center and from caudal to cephalic, or at least towards the venous angles, but the lymph behaves a bit differently in certain aspects in and around the liver. Nevertheless, the pressure gradient phenomena will affect the movement of lymphokinesis. One aspect is when we have tissue pressure anywhere in the body, meaning connective tissues responding with extra tone, which could be responding to the vascular system, that's going to affect the flow of lymph back towards the center, remembering that the lymph doesn't really have a central pump the same way that the vascular system does. So we get this phenomena of the lymph and venous blood almost being suctioned back because of the negative pressure in the mediastinum. And of course, we do have some when we're moving, it does help lymph move, and lymphangions do encourage some pulsation, and there is some recruitment of connective tissue to support lymphatic movement back towards the thoracic duct and towards the terminus. Now, dealing with the mediastinum, the biggest concern we have with the mediastinum is that if there's increased pressure in the mediastinum, challenging the negative requirement, the negative pressure requirement above the diaphragm, what this does is it will create a lymphostasis. Now, this is the typical lymphatic diagram. There's no distinction in this diagram between the deep and the superficial lymphatics. It's difficult to have an appreciation for that, even though it does include a great deal of the lymphatic structures. But it's hard to get that three-dimensional sense of it. So as I break down the mediastinum today, I'm going to endeavor to really introduce that whole idea of the multi-directionality of lymph in the mediastinum, going from deep to superficial and superficial to deep, and we'll go into more detail with that as I go along. And again, I'm going from head to toe just for anatomy's sake, in order to cover the entire body, but I always want to remind the viewer that that's not the way that lymph is moving in the body. So an important consideration also in lymphokinesis is what role the organs have in lymphokinesis, and that's going to be majority of what we're talking about today, organs and structures. In general, all organs in the body have lymphatic collecting vessels that are responsible for draining the portions of the tissue or organ that is nearby the vessels. The lymph lines typically follow the path of least resistance as they accompany tubes and vessels on their way back to the terminal points. And this is again the concept that the arteries and veins have accompanying lymphatic structures and lymph nodes that almost wrap around. Some are run in parallel, some will wrap around like vines with their leaves around a branch. And in this case, it would be the lymphatic structures and the lymph nodes representing the leaves. All the while going against the arterial flow and often succeeding where the resistance to lymph flow is limited. So this is a key component, again, talking about the pressure gradient phenomena, when ideally we have optimum arterial flow, but if there's something that's altering, creating a limitation, then that's going to affect how the lymph is moving and will lead to lymphostasis. And this is stuff coming from, again, Frank Millard. This is 100 years ago. This Canadian DO who wrote a fantastic book on the lymphatics. Now I'm going to cover the liver in the next presentation, but it is important to bring it into this discussion because of its articulations with the diaphragm, since we will be covering the diaphragm. The liver is the chief organ in systemic pollution. That is, in the majority of cases, the liver is involved primarily and the other organs are affected secondarily. If the lymph drainage of the liver is blocked, it is only a short time before some other organ will take on a diseased condition. Some other quick considerations for the liver and lymphokinesis. The liver produces about 1 liter of lymphatic fluid each day from the protein-rich fluid of the perisinusoidal space, otherwise known as Dissay spaces. From the Dissay spaces, the lymph then flows along the sinusoids and the efferent inlet venules towards the surface of the lobuli. The Dissay spaces are bordered on one side by the intrahepatic blood capillary sinusoids of the portal vein, which we will come back to later on in this discussion, and on the other side of the hepatic cellular plates. Just a quick diagram looking at a representation of the spaces of Dissay. And this diagram is entirely accurate, mostly because the hepatic vein is mislabeled. It should actually be blue, and this should be the colors are wrong here. That's basically what I'm trying to say. The Dissay spaces act as pre-lymphatic channels inside the liver, and you'll hear the term pre-lymphatic brought up a lot. They are structures that are there, and they are working on behalf of the lymphatic system, but they are not necessarily considered lymphatic structures. These channels travel to the initial lymphatic vessels situated in Mall's periportal spaces, also inside the liver. Pre-lymphatic channels also occur in the spinal cord and in the brain. The liver has intrahepatic lymph capillaries that are in the interlobular connective tissues inside the periportal spaces. The lymphatic structures inside the periportal spaces also receive lymph from a lobule of the portal vein. Just to finish up with a little briefing on the liver. Here we have the liver in purple, and you can see we have the inferior mesenteric vein. Inferior mesenteric vein here, and the superior mesenteric vein. And both of these veins obviously are collecting blood from the small intestine and colon, directing it back towards the liver. And there's a distinction that occurs at the liver where the the superior will go towards the right lobe, the inferior will go towards the left lobe. Not all of it, but you can see that there's the clear division here when you consider the articulation here in this particular area. I'm going to do it in green right in here. All right. And I'll get into more important aspects of the difference between the left and the right lobes of the liver. But this portal movement of blood coming back is also accompanied with some lymph vessels in the area. And as I say, there's a lot more to learn about the liver, but we're just going to move on and dive into specifically going above the diaphragm and getting into the mediastinal lymphovascular terrain. Looking at the mediastinal lymphovascular terrain, we have interconnected chains of deep lymph nodes and capillaries that travel to and from organs, weaving into one network supported by what I would call the central chain of Philippe Drouel, which would be connective tissue structures, which we'll cover a little later. We have the MALT, the mucosal associated lymphoid tissue, inside all tubular structures of digestion and respiration. Lymphokinesis within the network travels from deep to superficial and superficial to deep, depending on what has the path of least resistance and what activities we're doing. So it's going to be different when we're sleeping as opposed to when we're working out, or as opposed to when we're sitting and working at a desk. The lymphatic system will respond accordingly to the demands of the body. Not all the lymph is always directed in a cranial direction, as certain change of lymph nodes travel caudally before diving deep towards the thoracic duct. The thoracic duct travels through the mediastinum to terminate in the venous angles. Many lymph nodes connect directly with the thoracic duct deep inside the body. When we're talking about the mediastinum, it's an area, it's inclusive of organs such as the thyroid, the thymus, the lungs, the heart, includes structures such as the esophagus and the trachea, include the pleura, the pericardium, and of course the diaphragm. The diaphragm is not limited to the mediastinum per se, because it also contacts the liver, the spleen, and stomach below it. Spinal column and ribs act as a container for the contents of the mediastinum, using layers of muscles, connective tissues, bone, fascial layers, and pleura to envelop the lymphovascular and nervous systems. And of course, we're going to have some fluidic composition as well, intercellular, extracellular, and interstitial fluid in the mediastinum as well. The entire container can be viewed as a pressurized system designed for the delivery of oxygen-filled blood to the periphery, as well as providing a passive suctioning of blood and lymph back towards the center. Mediastinal lymph nodes. The right side has extensive lymph nodes that are lateral and anterior to the trachea. We'll cover some of these in some diagrams. There are retrotracheal and prevascular lymph nodes located in front of the great vessel at the back of the trachea. There are also posterior mediastinal nodes located on the back side of the pericardium. On the left side, we have nodes that can be found surrounding the upper border of the aortic arch and left upper lobe bronchus, where the left brachiocephalic vein crosses the trachea. There are also subaortic lymph nodes in the aortopulmonary window lateral to the left pulmonary artery. The pulmonary ligament nodes are located in the ligaments themselves, as well as paraesophageal nodes. And this phenomena is consistent in the body, where many ligaments have nodes or lymphatic structures embedded inside them. Involvement of the lymph nodes in this area have prognostic implications, which can influence the choice of treatment for cancers. Pulmonary nodes connect to bronchopulmonary nodes, which will join with the tracheobronchial nodes. The heart and posterior mediastinum are drained by afferents of the tracheobronchial nodes. More detail on the mediastinal lymphokinesis, the movement of lymph within the mediastinum. There's a consistent trend towards fluid accumulation in the lungs, as the lymphatic circulation will be drawn to an area of higher than normal pressure. So this is what I was saying, where if there's too much pressure in the mediastinum, lymph can be drawn towards that area, causing lymphostasis, obviously, which has implications for infections and degenerative tissue abnormalities. The lung interstitium responds to normal hydrostatic pressure due to the pulmonary veins returning 80% of the blood back to the heart. When there's sufficient resistance to lymphatic flow, there will be an adherence of endothelial cells limiting the removal of lymph from the interstitium. On the other hand, increased pulmonary capillary wedge pressure that accompanies pulmonary edema will result with the left-sided heart pump obstruction or failure. So the implications of lymphostasis definitely can have an effect on the cardiovascular system. Pleural effusions will develop in early stages due to the accumulation of lymph, meaning the lymph has to go somewhere, so the body is going to store it. I mean, in the cases of edema, certain cases of edema where you have accumulation in the lower legs or ankles or feet, here the body's trying to find locations to store the lymph, so it ends up with pleural effusions. The space between the pleura and the lung. Pulmonary lymph is required to flow at a higher or identical pressure as it is produced locally in the interstitium. In cases where patients have a singular ventricular defect with the heart, the increased pressure is associated with protein-losing enteropathy, plastic bronchitis, and coalesce effusions. Just look at some pathology, mediastinal lymphatic pathology, before we get into the anatomy. Retrograde flow from a traumatic leak at the thoracic duct terminus results in a backflow to the lung or mediastinum. That's going to be up near the venous angles. This condition is called pulmonary lymphatic perfusion syndrome and exhibits a lack of central lymphatic flow. It's also been noted that almost all patients who experienced a pulmonary lymphatic perfusion or a leak in the thoracic duct had similar symptoms as patients who had increased central venous pressure with secondary impaired drainage of lymph. Now that doesn't surprise me because of the proximity of the thoracic duct to the vena cava. When there's a failure with the right side of the heart, the lungs can be conflicted as they are required to drain at a higher pressure than is available to them. When the lung is normal, the pulmonary capillary pressure and the pulmonary arteriolar pressure are higher than the available central venous pressure, which allows for ideal reabsorption of lymphatic fluid. Just talking about plastic bronchitis, lymphatic-related pathology associated with congenital heart disease. Plastic bronchitis is a disorder that can cause severe breathing difficulties. It's a condition where buildup in your airways forms into casts that look similar to tree branches. The casts are made of mucus and cellular materials that have soft rubbery consistency. You might cough them up as your lungs try to clear the airways. Disease of the lymphatic system is caused by abnormal lymph flow. And symptoms include a chronic wet or dry cough and shortness of breath. And just here's one image of what that might look like as it kind of this forms sort of a tree-like structure within the airways. And obviously that's going to impede the cause is contributing factor is impeded lymphatic flow, and it's just going to lead to bigger and bigger problems with the respiratory system and affect the heart, as it's going to have to work much harder to fulfill its requirements in the area. Another lymphatic-related mediastinal pathology is the coalesce effusions, it's called chylothorax. A serious condition in which lymph from the digestive system accumulates in the chest cavity. Symptoms include shortness of breath, commonly caused by leakage of lymph from the thoracic duct or chyle migrating from the abdomen via the diaphragmatic opening. It can also correspond to pulmonary lymphatic perfusions. Both of those are the result of an overload or dilation of the thoracic duct. And I will talk a little bit more about the thoracic duct coming up, because it does have a capacity to contract and dilate, and it can be under various pressure loads as well. Here we have an image, a three-dimensional reconstruction of the computed tomography scanning without intravenous contrast after intranodal lymphodal lymphangiography. The lymphodal in the lymph duct is shown in blue. Abnormally dilated thoracic lymph ducts run dorsal from both sides of the abdomen aorta and inferior vena cava and descend to the posterior mediastinum, with retention of the lymphodal at the level of the 4th to 6th thoracic vertebrae and collateral into the right subclavian vein from the thoracic duct. So the implications in this image are showing, I'll just do it in red. So ultimately that thoracic duct is traveling up, kind of travels on the left, and then it kind of veers a little bit to the right, generally speaking, in most people. And then there's a bifurcation leading to the left and right venous angles. And in this instance, what we're seeing is, due to the increased pressure, you get distortions in this area of the thoracic duct, and you will, that's where you get the effusions, the leakage that occurs from the thoracic duct itself in these particular instances. Just an x-ray. Also, we can also see here the effusion that's happening. The x-ray is picking it up on the inside. And so you get the fluid. So basically what we're looking at is we're looking at fluid that gets in between the lungs, more essentially in the center of the mediastinum, around the thoracic duct, keeping in mind that that thoracic duct does come down from below and makes its way up to connect with the venous angles. So ultimately, something is happening in that thoracic duct where that's causing a type of leakage. And because it is a tube and it is has a propensity, it's required to dilate and contract in response to the cardiovascular load. So if we're under exercise, you're going to get a change in the diameter of the thoracic duct. The problem occurs when if we add the diaphragm into this image here roughly, is when something occurs in the system that causes these pressure gradients, which being the up above the diaphragm, we are supposed to have a negative pressure gradient, and below the diaphragm we're looking at a positive pressure gradient. And as I've said, you can obviously there are other implications around the pericardium, which could also have adhesions or be the heart muscle itself can also be contributing to pressure gradient imbalances. But All important factors that could potentially lead to some of these conditions of leakage of the thoracic duct. More specifically around the pressure gradient dynamics, the lungs are responsible for the intake of oxygen into the blood as well as the removal of carbon dioxide. This complex process is supported by the structural functional characteristic of the thorax, where I was talking about the pressure gradients above and below the diaphragm. The combined efforts of the diaphragm and the muscles of respiration work together to create a negative pressure within the pleural space. The negative pressure in the pleural space will surround the lung and cause it to expand. This results in a decrease in interalveolar pressure, and this triggers the movement of air through the upper respiratory tract into the airways. This includes the trachea and then to the alveoli, where the exchange of gases occur. There's a physiology of respiration and under optimal conditions in terms of the design of the body and the role of the pressure dynamic that's occurring during the respiration mechanics. In general, mediastinal pressure gradients. Above the diaphragm, the mediastinum produces a negative pressure gradient, and below the diaphragm, there's a positive pressure gradient. This is designed to allow for blood and lymph to be attracted back to the heart and venous angles while supporting arterial blood flow to the extremities below the diaphragm. Optimal global lymphokinesis requires ideal pressure gradients above and below the diaphragm. Lymphostasis will occur under suboptimal pressure dynamics, and this leads to increased inflammation and tissue degeneration. Pathological conditions of an adaptational nature, such as hidden inflammation, will always involve suboptimal pressure gradients, which disrupt lymphokinesis and detoxification. And where this appears to matter greatly is when we are supine, laying in bed, which we will spend roughly a third of our time laying in bed. This is where those pressure gradient imbalances really start to take a toll because we're not moving, so that makes it more difficult for blood and lymph to fulfill its obligations. And the more resistance, tissue resistance, or pressure imbalances we have in the body, the more disrupted the lymphokinesis process and detoxification will become. And that leads to degeneration, increased inflammation, and then chronic symptomology will develop out of that. Now, I've spoken a little bit about the considerations for including edema as a osteopathic lesion. So in terms of edema and the pressure dynamics, excessive pressure buildup eventually leaves an enormous amount of lymphatic water load that needs to be transported, in spite of the fact that the larger lymphatic trunks must still be able to empty their contents while under increased pressure into the venous angles. This leads to more water being added to the lymph inside the lymph nodes all around the entire body. Then the flow resistance in the efferent lymph vessels increases. The result is an increase in both afterloads as well as preloads. Those are terms that are basically describing the metabolic byproduct of fluids, including lymph, in the body. And the afterload or preload is just a stage at which, at what stage is the fluid? Is it pre-absorption, or is it left over when you have a malabsorption issue, or I don't want to say absorption, but when it's not being effectively metabolically mitigated, properly physiologically mitigated by the various structures and tissues that are involved in absorbing and metabolizing the various different fluids. Hemodynamic insufficiency occurs as a result of the lymph vessels' inability to adapt to their double impairment, and cardiac edema will eventually present itself. What Foldy's talking about here is that in general, the more load, the more lymphostasis occurs in various parts of the body, the harder the heart has to compensate for that, because you're effectively increasing pressure in the body. Sometimes it will be reflected in an increase in blood pressure, which is essentially a measurement of how hard your body is having to work to deliver blood to all the various areas of the body. requiring it to move through when it's climbing higher, you could argue that it's working harder to work through tissue and resistance. And I include pressure gradient and fluidic pressure in that as well. And eventually, the less movement you have in and around the mediastinum due to the increased pressure, the more lymph and fluid will collect in the area, further loading and putting pressure on the area, and so that edema that can occur or is essentially being stored in and around the area because it just gets trapped and has nowhere to go. In terms of the interstitial edema and pressure gradients, the interstitium is now recognized as an organ. It is a tissue in and amongst other tissues in between organs in the body. When mechanisms that are required to protect against edema fail, the results can result in an increase of interstitial pressure and a reduction in effective ultrafiltration rate. That means that the lymphostasis begins to develop. The effective ultrafiltration rate will remain unchanged if the interstitial pressure does not change. In terms of being mobile, moving around during the day, that's going to have an effect on the pressure gradients, which will help assist the ultrafiltration rate. But again, when we're laying down in bed, that is no longer going to work in our favor. Lymph formation will increase if there's an increase in interstitial pressure. This explains why all cases of generalized edema primarily appear where the fluids can easily accumulate in the area of the interstitium that is most compliant. So the lymphostasis will occur in the areas where the lymph will go to the path of least resistance, and then it'll get stuck there and get trapped there. Looking at non-injury edema as an osteopathic lesion, adaptational edema perceived as weight gain or bloating and pressure. That's a big one. A lot of people think they've gained fat, but in fact they're actually holding on to fluid. Edema results in what's called terrain fatigue, as the 4 stages of pathophysiology trend from physiological, physiopathological, pathophysiological, and then eventually pathological. And so that's a slow process, degradation process, where latent fluids and toxicity will eventually evolve to something more cynical. And edema is also an indicator of allostatic load, which I covered in my second presentation, part 2. Typically, the area of enlargement or edema includes toxins or infection and is often accompanied by dysfunction in the nearby lymphatics. That's coming from British osteopath Tom Dummer. When discussing lymphostasis, we want to touch upon the topic of hidden inflammation. Lifestyle diseases have a cynical nature as the metabolic implications play themselves out within the ecosystem of the human body, lurking beneath complex physiological degeneration in the form of developing tumors, heart disease, diabetes, obesity, psychiatric and especially neurodegenerative diseases. There may also be a few signs or symptoms of hidden inflammation, but it smolders away, occasionally expressing itself as autoimmune disorders, arthritis, eczema, psoriasis, chronic pain or swelling with redness or heat. This requires knowledge of working in the gray areas within the terrain. Successful treatment of the terrain or gray area lies in obtaining the correct roadmap and understanding the direction of flow and providing the right tools. There are also implications of surgeries on inflammation. Recent research sheds light on the damage to lymphatic function following cardiac surgery. The surgery is invasive and appears to disrupt the pressure gradients around the cardiac mechanism, thus leading to stagnation of lymph. Given the proximity of lymphatic vessels to cardiac structures, manipulated during surgical repair of congenital heart defects, trauma of the thoracic duct can occur. In addition, after congenital heart surgery, abnormally increased venous pressure is common. The effects of the abnormal physiological states prevalent in congenital heart disease on the lymphatic circulation are now being discovered. Thoracic duct response to surgeries. Further research indicates that following surgeries, there are factors that alter lymphokinesis, leading to incidence of lymphatic leaking from a branch of the thoracic duct. In addition, there can also be incidence of retrograde lymphatic flow from the thoracic duct to the mediastinum, pulmonary lymphatic perfusion, and central lymphatic flow congestion, all of which lead to abnormal black flow to the collaterals. The central increase in venous pressure leads to secondary impaired lymphatic drainage. In terms of the lungs, the lymph from the lung is required to drain at a higher pressure than is normally created following surgeries. The normal lung has pulmonary capillary wedge pressure and the pulmonary arteriolar pressure, which are both higher than the central venous pressure. This allows for the regular absorption of lymphatic fluid. When the venous pressure is higher following surgery, there can be a trend toward fluid accumulation in the lung since the lymph will not flow in the presence of higher local pressure. There are also non-surgical implications regarding lymphostasis in the mediastinum. We can have complicated vertebral lesions, including inter- or interosseous lesions that contribute to somatovisceral dysfunction, compromised central nervous system participation via compaction or limitations of the brainstem affecting organ or aspects of the vascular tree, organs or structures that embody excessive tone or densities within or around them as a result of kinetic trauma or accidents, organs that can present as being off axis or are not liberated from surrounding structures, including adhesions, and limitations of Philippe Druel's central chain, organs embodying emotional imprints, such as emotional trauma, organs undergoing degenerative changes to tissues such as fibrosis as a result of chronic infections or hidden inflammation, organs who have lost their original shape in the form of allostasis due to the adaptational requests of homeostasis, and of course congenital abnormalities that present as mechanical or metabolic disadvantages. In terms of what would be called, from an osteopathic point of view, the complicated lesion, an osteopathic lesion or somatic dysfunction is a mechanical and physiological reaction in somatic structures. This includes trauma, prolonged or chronic mechanical stress, psycho-emotional stress, and disturbed organ or visceral function. There would be an indication of an interrupted operation of the body reflected in the structure, physiological systems, and as an integrated ecosystem. That's coming from Tom Dummer. If we're looking at osteopathic lymphatic lesion classifications, Friat contributed to the classification of general osteopathic lesion in 1954 by presenting the idea of a total body lesion, which was beyond mechanical considerations. Her description included emotional, psychological, physiological, environmental, nutritional, and spiritual factors influencing the total human being. Foundations of Osteopathy gives recognition to osteopathic pioneer Frank Millard and his suggestion to remove any obstructions to lymphatic flow by treating somatic dysfunction that presents along the detoxification pathways, fluid return. It stands to reason that tissue strain in the area of lymph vessels will increase the resistance of lymph flow through those vessels. In terms of an osteopathic approach to lymphatics, there is one perspective presented to the osteopathic community which revolves around the work of J. Gordon Zink and his emphasis on describing the respiratory circulatory model. Dr. Zink was influenced by the work of Millard, and his model is deemed an expansion of the Millard approach. This included placing emphasis on the fascia and any restrictions that would create resistance to venous and lymphatic flow. He was also interested in creating pressure differentials within the cavities to improve lymphatic flow. He also assigned priority to maintenance of lymphatic homeostasis by ensuring the correct function of the thoraco-abdominal pelvis pump. In terms of talking about the heart and any complicated lesions, Dr. Hoover describes a complex lesion as a severe functional disorder resulting from loss of tissue adaptability. Here we have a pre-existing dysfunction and another lesion overlaid on top of this. Hoover includes the example of a heart problem in relation to a complex lesion at T3 or a gastric ulcer with a complex lesion at T5. We're going to begin the investigation of the mediastinum organs, starting with the heart. The heart consists of two paired valve muscular pumps which unite to form a single organ. The two pumps are structurally interwoven in a fibromuscular network along with conduction tissues. Each individual pump is its own heart, and they are physiologically separate while contributing to the double circulation phenomena. In total, there are 4 cardiac chambers. 2 of the atria receive blood from the venous system, and they send the blood to the 2 ventricles, completing a strong contractile force that propels the blood into the 2 main arterial trunks. In terms of the role of the heart depends on the availability of the parasympathetic state. The rhythm of the heart changes under moderate strain and sympathetic mediated blood pressure. The heart can be called the central hub of the organism, supported by hormones circulating in the bloodstream, as well as the sympathetic and parasympathetic nervous systems. The heart has an electromagnetic field that is detectable only a few meters from the body. The changes in the heart are shared by the entire body. It has been determined that each organ has its own biomagnetic field and that these fields are interrelated by their resonance. Electromagnetic fields are considered important in the developmental matrix and in the shaping of morphogenesis in living entities. And this is observed in the embryological dynamics that you can find by studying people such as Blechschmidt. As a side note around healing and the heart and its electromagnetic frequencies, in situations where there is tissue damage in the body, a positive injury potential is established as an electrical current in the tissue that is positively charged against the rest of the body. The tissue will trend towards a negative charge in the healing cycle before returning to its original frequency. In terms of the position of the heart, the right portion lays over top almost all of the left heart as it follows a gentle curve, excluding the apex and a left-sided strip. The right heart comprises the largest portion of the anterior surface, and its direction of flow is ascending. The left heart is positioned posteriorly to the right heart and is largely hidden by the right heart chambers when viewed from the frontal plane. Approximately 1/3 of the heart lies to the right of the midline in an oblique position and is a hollow fibromuscular organ. Its oblique position can be characterized as a deformed pyramid as the base faces posteriorly to the right side when the apex of the heart faces anteriorly and to the left. Let's look at the left side of the heart. The left heart begins at the left atrium. The left atrium is thicker than the right atrium, even though it has less volume than the right. The left atrium manages all the pulmonary inflow of blood that is oxygenated, as well as minute coronary venous inflow. During contraction, the left ventricle will fill up via the left anteroventricular orifice, which has the support of the mitral valve for guarding the entrance to the left ventricle. When there is a contraction of the left ventricle, there will be an increase in cavity pressure inside the apical trabecular component. This will in turn close the mitral valve and open the aortic valve, allowing the ejection of blood into the aortic sinuses and aorta. The function of the left ventricle The left ventricle is a powerful pump that must sustain pulsatile flow within a highly pressurized arterial system, and its walls are 3 times the thickness of the right ventricle. It is roughly cone-shaped, and its inferior cardiac surface articulates with the sternocostal as well as the left diaphragmatic surface. The left ventricle will mostly rest upon the central tendon of the diaphragm. The left ventricle also forms the conical apex of the heart and is facing downward, forward to the left. Overlapping the apex is the left lung and pleura, and it is directly behind the 5th left intercostal space medial to the midclavicular line. The left surface of the heart has the pericardium separating it from the left phrenic nerve, as well as being separated from the pleura on the left due to the deep concavity of the left lung. Moving on to the right heart. The right atrium is the beginning of the right heart, and it will receive blood from below, from the inferior vena cava, and from above, from the superior vena cava. There is also venous inflow to the heart from the coronary sinus. The incoming venous blood flow will pass through the guarding tricuspid valve as it crosses over into the right atrioventricular orifice before entering the inlet of the right ventricle. The tricuspid valve will close during contraction of the right ventricle, resulting in the propulsion of blood from the muscular right ventricle into the pulmonary trunk. There is relatively low resistance at this point when the blood enters the pulmonary vascular bed. Now, there are also some observations that the blood travels in a spiraling motion through the heart, as well as through the arterial system. You can see how the heart would set the stage for that, creating sort of a spinning motion as it's being sucked in and pumped out. Looking at the heart as a master of fluids, the role of the heart in terms of physiology is to ensure delivery of blood to the organs and tissues in accordance with their relative needs. Preload and afterload are a noted concept to cardiologists. The volume of blood flowing at any given moment in the atria is known as the preload. The afterload is determined by the existing blood pressure in the aorta or pulmonary artery and by the amount of resistance to blood flow in the periphery. When the heart manages the myocardial load effectively, it is known as cardiac sufficiency. If it cannot handle the myocardial load, then it is termed cardiac insufficiency. And I think it's important to note that when we are measuring blood pressure, we're not really getting information on the heart per se. We're only getting information on how hard the body is working to maintain blood delivery to all aspects of the body, in particular to the left arm, where the most common location for taking blood pressure. It's also important to remember that the heart itself relies on adequate blood pressure. For example, the left coronary artery is often a critical artery. And so any alterations or pressure gradients surrounding the heart or pericardium could have a profound impact on the blood supply to the heart itself. This would affect the muscular contractions of the heart, and it would affect the efficiency of the heart to sustain its role in bringing in blood and pushing it back out again. Looking at heart pressure gradient physiology, compression of the heart tissues affects the local initial lymphatic network, lymphatic collectors, and endothelial cells by limiting the flow of lymph. This affects the lymph flow back into the interstitial tissues, activating what's known as the safety valves. In this matter, the lymph in the interstitial tissues behaves as a reservoir. The Starling resistor effect. protecting the heart from volume overload. So that's a good example. When we say the interstitial tissues behave as a reservoir around the heart, this can happen anywhere in the body that we have interstitial tissues. Quite often, the lymphostasis is occurring in areas that have a pressure gradient imbalance, and so the body is storing lymph there because it can't successfully mitigate it and move it to the next place in the lymphatic the detoxification pathways. In terms of looking at left ventricular cardiac pathology, left ventricular dynamic flow obstruction will occur with instances of hypertrophy of the heart muscle as the myocardial wall will thicken. The anterior mitral valve cusps will be pressurized to move anteriorly during systole, and there will be a mid-systolic closing of the aortic valve. This condition has an expansion of fibrotic components replacing the cardiac myocytes. Looking at right ventricular cardiac pathology, the right ventricular failure will result in an increased blood capillary pressure and in an increase of net ultrafiltration. The reaction to this disturbance in the Starling equilibrium results in a decrease in blood volume, a decrease in venous return, which is the preload, and a decrease in cardiac output, and a decrease in blood pressure. As well, there's an increase in renin, angiotensin, aldosterone secretion, increased vasoconstriction, a decrease in renal blood flow, an increase in peripheral resistance, and an increase in extracellular fluid space, as well as an increase in cardiac output and blood pressure. This disturbance in the Starling equilibrium causes the compensation of an increased lymph flow per unit of time. Now, it increases the lymph, but the lymph is not necessarily moving in the right direction. It will act in a stasis, as I described in a reservoir fashion. When the lymphatic vessels cannot adapt to the situation, it can lead to cardiac edema. Furthermore, during right ventricular failure, the lymph vessel workload doubles. So it creates a vicious cycle where you get an overload, lymph's not moving, the heart has to work harder. You also will get lymphostasis around the heart, perhaps in between the pericardium and the heart muscle. However, they're referring to cardiac edema. So in terms of the hemodynamic insufficiency, it's a result of right ventricular heart failure and is a critical factor in developing cardiac edema. Observing the right ventricle diastole, the blood flow travels from the right atrium directly into the right ventricle, and during right ventricular systole, the blood will depart from the ventricle to the pulmonary artery with the help of a muscular contraction. Weakened muscles in the right ventricle will result in less blood being expelled into the pulmonary artery, and there will be blood remaining in the right ventricle. This remaining blood will mix with the incoming blood from the right atrium systole and cause the ventricle to expand. The expansion leads to congestion in the right ventricle, which will spread the right atrium, the two vena cavas, and finally all the veins in the body as a response. Venous pressure increases as a result of the entire circulatory system. So this brings into question when we see peripheral issues such as varicose veins, although we can easily see that they are a localized phenomena. I think it's also important to consider that there is something going on centrally in the vascular tree, quite possibly in the mediastinum. So before I would recommend or share my opinion on someone that would be who's had varicose vein surgery suggested to them, I might I might explain to them that there could be other contributing factors going on in the body, whereby if we correct some of these imbalances in the body, we could get a decrease or an improvement in the presentation of something such as varicose veins. And this, I would have to say, would include lower extremity edema in the lower legs or ankles as well. We can also look at general venous hypertension. It includes the muscles of the heart, further limiting lymphatic drainage of the area. This will be followed by cardiac asthma and pulmonary edema. Once there is the introduction of edema to the lymphovascular system, a new set point or pathological equilibrium must be established. Here we have this balance between allostasis versus homeostasis. What is the cost to maintain homeostasis? This is what presents itself as allostatic load. This requires the adaptation of the net ultrafiltration volume declining or the transport capacity increasing with the hypertrophic enlargement of lymph vessels. There's great pathophysiological significance in cases of lymphovascular system insufficiency, as all types result in edema. This is coming from Dr. Foldy, who's a renowned expert on the lymphatic system. So it does bring into question how we view edema occurring anywhere in the body, and why I feel it's important not to be myopic in terms of looking at local causes of edema unless it's injury related or a chronic repetitive movement strain type of itis that's occurring in an area. It does highlight the importance of assessing the vascular tree and looking at the components of Philippe Drouel's central chain as a guide to try and help organize the pressure gradients in the body by removing tensegrity imbalances and possible density issues. Regarding the interactions of the central nervous system and the heart, cardiac and respiratory rhythms exhibit cycles that interact in phases, and they are synchronized with the rhythmic cycles produced at the brainstem. This is accomplished by some cell groups situated at the brainstem that participate in the cardiac tonicity, cardiac rhythms, and respiratory rhythms. The basal ganglia development of the brain is the result of embryological development compression phenomena due to the brain expanding around the third ventricle. Brain development is also supported by hydrostatic pressure of the cranial ventricles and the information it receives from the hydrodynamic heart output, along with the increased volume of liver expansion. And I think what's important to take away from this, in terms of using an approach to liberate any issues with the heart by reintroducing its optimal positioning or size or shape or function, I think it's important to consider that if you are working from the head to toe, it will make it easier to access the heart or mediastinum by ensuring that the brainstem and the associated blood flow of the internal, external carotid, and posterior vertebral arteries are properly functioning, so that you do have the PRM expression when you are assessing the cranial bones, as well as accessing any biomechanical limitations of the upper cervical spine. It never hurts to start at the top and provide some balance between the sympathetic and parasympathetic, allowing the vagal tone to have a positive influence on the mediastinum and heart in general before you go in and apply any specific techniques to an already suboptimally functioning cardiovascular system. Just to support that point, this image will give you an indication of the collection of the nervous system as it descends. Now, this image doesn't show it coming down from the brainstem, but it does give us an indication of some of the nerves. Of course, phrenic nerve is always an important one. And you'll definitely be getting your vagal nerves. Here we got the right vagus nerve over here, right phrenic nerve as well. And this is sort of a general image, but it does show you, even when you see the aortic arch here, you can really get a sense of the interactions of the sympathetic and parasympathetic nervous system. That's it as it's coming down, and this doesn't include, I don't think, the ganglia that are the stellate ganglia, which are going to be somewhere at the base, at the top of the apex of the lung, at the interaction of the thoracic and cervical spine. Now, there are also perspectives that, in terms of examining cervical spine patterning or lesions, we can also argue that resolving issues of the mediastinum and pericardium, etc., will have a profound impact on the range of motion of the cervical spine. So it's a chicken or egg scenario, but I do think in general, safety first, and anything you can do, if it's required, to work with the central nervous system and the brainstem prior to entering the mediastinum is always a great way to ensure that you probably be more effective in your goals to liberate the area. We can also consider Rudolf Steiner's hydraulic heart theory. Venous blood flows into the right atrium with the help of the structural water phenomena. Pressure in the right atrium increases to open the tricuspid valve, allowing blood flow into the right ventricle. Fluid arriving at the right ventricle converts into a vortex before emerging out of the pulmonary valve. Now, this is that spiral aspect that I discussed a bit earlier. There are two processes happening simultaneously. First, there's an increase in momentum due to the hydraulic gating mechanism. Second, the form of the blood changes from a laminar flow into a vortex. And my understanding is that vortex is continued as the blood is moving through the plumbing of the arterial system in a spiraling motion. Furthermore, the activity of the right side of the heart converts to the vertically oriented laminar flow of the venous flow into a vortex, a horizontal flow, as the blood goes from the right ventricle to the horizontally positioned lungs. Blood then travels through the lungs, again moving into the capillaries as a result of the structured or structural water and its tendency to flow within the hydrophilic tubes. A strong explanation on how or why blood can move through the high resistance environment of the lung capillaries, keeping in mind that you have highly viscous blood with blood cells suspended in plasma and whose diameter is almost as large as the capillaries, moving effortlessly through an extensive network of lung capillaries. After reaching the capillaries, the blood flows back to the left atrium of the heart, serving as a temporary holding area waiting to open the mitral valve. The spiral blood flow continued. Pressure builds up in the left atrium, the gates open, and the blood flows into the left ventricle. This is followed by the left ventricle converting the laminar flow into a vertically oriented vortex. Vortex flow, along with the built-up pressure, opens the aortic valve and the blood is released through the arteries to the rest of the body. Further evidence that the heart is not a pump is that the aortic arch during systole does not straighten, but actually bends inward to form a more acute angle, and this has been found with angiograms. The aortic arch bending is due to a negative pressure and a suction force rather than a pushing blood under force. The end result is the formation of vortices that send the blood spinning towards the arteries. In terms of the heart and its associated lymphatics, a disturbance in the Starling equilibrium causes the compensation of an increase of lymph flow per unit of time. Now, that Starling equilibrium will be affected by pressure gradient imbalances. When the lymphatic vessels cannot adapt to the situation, it can lead to cardiac edema. Furthermore, during right ventricular failure, the lymph vessel workload doubles. The heart is surrounded by 3 lymphatic plexuses, which drain into one subpericardial plexus. The subpericardial plexus receives lymphatic vessels that are associated with both ventricles. So, looking at an image of the mediastinum, we try and appreciate how the lymphatics moves from superficial to deep. Now, some considerations here are, yes, we have the diaphragm that's appearing here. And we have the aortic arch in red, and then here the pericardial sac. So this is just looking at the lymph nodes that are outside of the pericardial sac, deep in the mediastinum. And as you can see, we also have superficial chains of lymph nodes, and we also have the lymph nodes, brachiocephalic lymph nodes coming off the cervical spine, draining into the venous angles. What's important to remember is that the direction of the lymph goes both ways. It will go, if we add the thoracic duct in here, the direction of the lymph and these chains goes towards the duct, deeper, and also some of the deeper lymph nodes will go, or surrounding the thoracic duct will go out to the superficial nodes as well. It will go in the direction that is the path of least resistance. So there are multiple chains, and it's not just the superficial lymphatics. So here you see the axillary lymphatics, which is a common popular place for manual lymph drainage as a transit point to direct strokes into that area, so that the lymph can then be directed towards the, actually in this case it'd be directed towards the venous angles. Also important to note that through the diaphragm and around the diaphragm, there are lymph nodes in and around the diaphragm, and they're also, you're connecting down through below the diaphragm, lymph nodes are coming up. Now what's not included here is the organization of lymph nodes around the liver, which would be here in this area, and what happens as a transit point. But if you watch my next presentation, we get into more detail of how the lymph travels in and around the liver, because it really is a hub. Now, generally speaking, in addition to what I've outlined, we have this direction of lymph coming down towards the venous angles from the cervical spine. We have lymph traveling up from in the thoracic duct, and we have lymph coming towards the duct and lymph going away from the duct. What else is notable here? So you can see why, when we're looking at situations when the thoracic duct is under pressure or duress, or if there's any leakage, why you would get some of the pulmonary effusions and hemodynamic insufficiencies that would lead to some type of lymphatic leakage. And of course, we don't have the lungs included in this image, but this just gives you an intro into why it's critical to consider the deeper lymphatics of the mediastinum. This image is a little bit smaller and a little bit harder to see, so I'm going to just highlight some areas here. Here we've got, this is around the heart, the aortic arch, and showing you some of the lymph nodes that occur around the aortic arch, mediastinal lymph nodes. You've got pretracheal lymph nodes, you know, all in and around here, cardiac lymph nodes. There's a bifurcation lymph node here. There's another left mediastinal lymph node. So in essence, you know, you can start to put lymph nodes all in and around the outside, connecting to each other in a chain fashion. And some of these are going to go, if we add artificially the thoracic duct, some of them are going to go drain towards the thoracic duct, some are going to drain up towards the venous angles, and some will be pushed out superficially to the more superficial lymphatics. It all depends on what the requirements are at that point, the pressure in the heart. So the lymph will behave differently if you're exercising versus if you're laying in bed. The exercise will increase the pressure in the mediastinum. That's going to temporarily alter the dynamics of lymphokinesis versus laying in bed where you're reliant more on the pre-existing pressure dynamics to hopefully guide the lymph to its terminal point where it's trying to get to. Looking just at pericardium lymphatics, pericardium only has a small number of lymphatic vessels. And there's a distinction between lymphatic vessels and lymph nodes. The vessels are the connections between the nodes. There are vessels on the lateral surface of the pericardium that communicate with the vessels of the adjacent mediastinal pleura, which terminate in the pre-pericardiac and lateral pericardiac nodes. Lymphatic drainage from the lateral pericardiac nodes drains along the phrenic nerve into the anterior mediastinal nodes. Lymphatic drainage from the pre-pericardiac nodes flows toward the peristernal nodes through the peristernal bundle. The posterior pericardium surface lymph nodes drain to the posterior mediastinal and bifurcation nodes. The basal surface of the pericardium is fused with the central tendon of the diaphragm and contains no lymph nodes. Here we have, again, the pre-pericardiac lymph nodes I was talking about are occurring around this area. Now, this image obviously would appear to be superficial, but these are not superficial nodes. Most of the nodes represented here in this section are actually quite deep. It's another good image showing the complexity of the lymph node chains. Again, here we have the diaphragm at the bottom, and we've got that pericardium here. I believe this is meant to be, this butterfly is meant to be the thymus. We've got the thymic lymph nodes in and around this area. We also have the thyroid up here. And note the connections of the deeper lymphatic chains that are coming down anterior on the trachea, connecting with the larger lymph nodes that are supporting the aorta and venous angles. We also have more superficial lymph nodes here that also connect to the deeper lymph nodes. So you can see, anytime you see these connections, the lymph has typically multiple directions it can go. In the scope of these chains, the lymph is designed to move. It can either move upwards or it can either move downwards, depending on where that pressure is allowing the lymph to move. And of course, down at the bottom here, you can see that outside of the pericardium, you have this collection of lymph nodes that are on top of the diaphragm. So it lets you see the importance of that diaphragm in relationship to not just the nodes that are associated with the diaphragm itself, but also in general that thoracic duct, which is traveling up through the diaphragm, is collecting that lymph from the lower extremity, from below in the abdomen, and pushing it up. So that the position of the diaphragm is critical, as is maintaining the ideal pressure gradients in this entire mediastinal area. Here we've got another view. Now in this one we've still got the diaphragm here, but we've also included the stomach here at the bottom. And we have the aorta. And note that this is occurring below the diaphragm. You have many lymph nodes associated in and around the aorta. Then we've got the pericardium here. And deep to the pericardium, again, we've got these collection of very deep lymph nodes and connecting, and I believe here we have the thoracic duct portion of it. So these lymph nodes are connecting to the thoracic duct, as are some of these superficial nodes that have the distinction of connecting. You can see these nodes are also connecting to the duct, but they're also able to move. Lymph is also able to move up through the chain to try and direct itself to the venous angles. Again, looking at the heart, we have cardiac lymph node here. This is outside the pericardium. There's that one called a bifurcation lymph node. There's even a sinus node. And we have left coronary trunk. These are lymphatic vessels, but there are no lymph nodes here on the outside of the pericardium. But the pericardium still has these lymphatic vessels that are supporting the pericardium. Cardiac ventricle lymphatics. The diaphragmatic surface of the left ventricle contains a large lymph vessel. This vessel leads through to the tracheobronchial node, traveling along the pulmonary artery and left atrium. The diaphragmatic surface of the right ventricle has lymphatic vessels that travel along the right coronary artery and then in the anteroventricular groove. The vessels will finally pass anterior to the ascending aorta and terminate in the brachiocephalic node. The coronary sinus is the largest venous vessel in the heart. Amidst the connective tissue of the myocardium, there are branches of lymphatic and blood capillaries that anastomose into a plexus. In some instances, venous stasis and lymphatic blockage can interfere with cardiac nerve function and contribute to tachycardia. That's coming from Millard over 100 years ago. So if we're just looking at principal veins of the heart, what's important to remember is that accompanying along with this structure, the branch-like structure, we do have lymphatic vessels that are supporting the venous and arterial, but this image just has the great principal veins of the heart. And then these in turn are connecting to lymph nodes that are located in and around the aortic arch, and as I've shown in the previous images. So you can see the importance of the pericardium having lymphatic support. And when you have an injury, vascular injury to the heart, you can see why it might impede lymphatic movement and also have an effect on some of the nerve conduction, which could feasibly, as Millard talked about, contribute to symptoms of tachycardia. The left ventricle lymphatics, there are two drainage territories in the anatomy of the ventricles, which can be divided into left and right. Lymph from the left territory includes the left ventricle and is conducted to the left coronary trunk through the tree trunks that ascend from the apex toward the base of the heart. There are two anterior interventricular trunks and a single left marginal trunk. The left coronary trunk descends between the left auricle and the pulmonary trunk before it ascends along the posterior surface of the pulmonary trunk to terminate in the bifurcation lymph nodes, and those are those lymph nodes that are associated superior to the pericardial pouch near the aortic arch. From here there are efferent vessels that send lymph to the upper cardiac lymph node, which sits between the brachiocephalic trunk and the superior vena cava. Coming back to this image, this is of course still not seeing the heart muscle itself, you're just looking at that pericardium. But for instance, that bifurcation lymph node located outside above the pericardium, and then we have brachiocephalic lymph nodes located also superior to the pericardium. Looking at the right ventricle lymphatics, the right-sided territory includes the right ventricle, and the lymph from this region flows into the right coronary trunk. The posterior wall of the left ventricle is often included in this territory as a variant. Keep in mind that the left ventricle is deeper than the right ventricle, and also 3 times thicker. The right coronary trunk reaches the aorta via the coronary sulcus and descends along the anterior surface of the aorta. It then continues to the origin of the common carotid artery to terminate in one of the mediastinal nodes. The lymph from the right coronary trunk ultimately drains into the left coronary trunk before terminating in the right venous angle. There can be several drainage variants involved, as well as adaptations depending on the individual, and ultimately the left coronary trunk is the main lymphatic drainage pathway of the cardiac conduction system. So some of the right ventricle drains into the right venous angle, but ultimately most of the drainage for the pericardium and heart is being drawn on the left side of the aorta and thoracic duct as well. This image here is just giving an indication of the vascular system on the left that's supplying the heart muscles, and the image on the right is showing the arteries and the lymphatic support. Now, the only thing to consider here is that in this image, the green is actually the vascular supply, and the red is the lymphatic structures that are adjacent and also supporting different aspects of the heart muscle itself. So this is underneath the pericardium. This is the type of lymphatic support that's needed while the heart is completing its pulsating motions, how many thousands of times a day. Now, looking at lymphatic vessels of the cardiac wall, lymphatic vessels of the cardiac wall have initial lymph vessels that form subendocardial, epicardial, and myocardial plexuses, which correspond to the 3 layers of the cardiac wall. Lymph leaving the one side of the subendocardial plexus drains into the myocardial plexus. On the opposite side, it drains directly into the epicardial plexus via valvular collectors, which transverse the myocardium along the branches of the coronary artery. So again, that coronary artery has lymphatic support that's trailing along with it. Lymph vessels of the of the myocardium form a plexus of loose connective tissue. There are a few vessels that accompany the myocardial branches off the there are also a few vessels that branch off the coronary arteries, which I've already mentioned. The subpericardial plexus forms a pattern that is like an equilateral rhombus, which is the same length on all four sides. The subpericardial lymphatic plexus presents in the area of the coronary sulcus, anterioventricular groove, and communicates with the lymphatic networks of the ascending aorta and the pulmonary trunk. Just an image here giving you an indication of the coronary sulcus, the base of the heart, and the apex of the heart for reference. This image is a three-dimensional schematic diagram of lymph vessels of the cardiac wall. So again, here we do see the red vascular branches of the coronary artery and the subpericardial plexus, the lattice of lymphatics that is interwoven into all of the muscles and myocardial plexus. So this is muscle, and it's just loaded up with lymphatic vessels. Now, there are no nodes in this image, in these images, but it would make sense because the heart is constantly moving and beating. So the job is just to ensure that the muscles, the detoxification in the area is being supported by this lattice or matrix of lymphatic vessels to be taken to nearby nodes and to be exited through the venous angles or back to the thoracic duct. A little more on the coronary artery lymphatics. In some instances, the lymph collectors on both sides of the right and left coronary arteries are connected to each other by supraarterial oblique anastomosis. The coronary lymphatic tructs start at the diaphragmatic surface of the heart and run in the coronary sulcus in an anterior direction. There are 4 different coronary arteries, and they all supply blood to the heart. The most common place for blockages is a branch of the left coronary artery called the left anterior descending, or LAD. So you could understand why or how the importance of the lymphatics in terms of supporting proper health of the blood flow, in particular that left coronary artery and its specific branch. This is just again that image. Again, we have the left coronary artery and the associated lymphatic vessels that follow along all the different branches. And the image on the right, as I mentioned, is same thing, except the arteries are yellow and the lymphatics are in red. Moving on from the heart, let's begin looking at the lymphatics of the lungs. There's a deep plexus that accompanies the branches of the pulmonary vessels and bronchi. There are superficial efferents around lung borders and fissure margins converging at the bronchopulmonary nodes. In some locations, there's little anastomosis between the superficial and deep lymphatics, except in the case of the hilum. In the peripheral parts of the lungs, there are small channels that connect the deep and superficial lymphatic vessels. The channels are capable of dilatation, which helps direct lymph from the deep to the superficial channels when outflow from deep vessels is limited by pulmonary disease. So, Standring is talking about pulmonary disease. I think we could add to that and just say in general pressure gradient imbalances or adhesions, anything that would be affecting the natural flow of lymphokinesis. The area is capable of adapting, and as I said, that lymph will travel in the path of least resistance. Continuing with the deep lymphatics of the lung, vessels from the upper lobe pass to the tracheobronchial nodes, and the lower lobe vessels pass into the inferior tracheobronchial nodes. Lymphatic vessels of adjoining lobes connect deep in the fissures, and the connections are not exclusive. The lymphatic vessels in the pulmonary lobes follow the central artery of the lobule and its accompanying veins. Non-follicular lymphoid aggregations occur in peribronchial sites and in motionless formations adjoining pulmonary pleura. Here's a good image showing us the bronchi coming off the trachea. And note the interwoven matrix of lymph nodes in the green here, interconnecting and actually wrapping around the brachia, also wrapping around the venous angles. We also have esophageal nodes located here at the bifurcation of the brachia. And of course we have the vagus nerves left and right vagus nerves coming down to blend into the mediastinum. Here's an image of the deeper lymph nodes and lymph vessels with the lungs. The heart is removed. So important things here, we have the thoracic duct traveling up through the center. And then we have some of the larger nodes like the inferior tracheobronchial lymph nodes at the bifurcation of the bronchi. And you can see that connecting to the pleura of the lungs, we have lymphatic vessels as well that are branching off. Now all of this ideally is moving the lymph back to the center, back towards the thoracic duct, but also it's going to connect into some of these other lymph chains that are going to go up and connect directly into the venous angles. So we have a confluence again of lymph coming down from the cervical cranial area and up from the rest of the body. Keeping in mind that there is a distinction between the left and the right venous angles, in that the left venous angles are receiving lymph primarily from the left side, left arm, both legs, lower extremity, the abdomen, and the right venous angles is receiving lymph from the right arm, right side of the cranium, cervical spine, and large portions of the liver and portions of the right lung will drain into that right side. Again, we can also see how we've got the diaphragm down here below and the connections of the lymph nodes traveling down through the diaphragm, which will connect to the cisterna chyli. So this whole mechanism here is under pressure. And again, we know that above the diaphragm it's a negative pressure gradient, and below the diaphragm it's a positive pressure gradient. So it's easy to see how you might have cynical diseases presenting themselves in any one of these lymph nodes if they become overwhelmed. Fundamentally meaning that if you have a lymph node that is not able to properly support, let's just take one at random here, this lymph nodes get enlarged or gets overwhelmed because it cannot connect properly to other nodes, then the lymphostasis does increase the likelihood of some type of a disease process overwhelming the lymph node itself, And as that lymph node becomes compromised, then we start to look at metastatic parameters, whereby the toxicity in an area affecting that lymph node, overwhelming a lymph node, will begin to move the toxicity further on to other nodes, causing a metastatic event. If we venture inside the lung looking at the alveoli, since there are no lymph vessels near the alveolar walls, the lymph must utilize other forces of physiological flow, and this occurs as a response to the coupled compartments creating their own clearance. Forces at play are represented as the Starling equilibrium, where we have the hydraulic conductivity moving in the opposite direction of the alveolar liquid and osmotic pressure. This creates a cross-flow velocity phenomena and replaces the presence of lymphatic structures. Increased pressure affects the alveoli, interstitium, and capillary membranes. So this velocity phenomena allows for the detoxification support for the alveoli, since there are not any actual lymphatic vessels or structures at that particular juncture. Here's an image depiction giving us an indication. Here's the alveoli, one in particular. Now you can see the interlobular lymph vessels here following along the pulmonary veins. You can also see the lymph vessels accompanying the bronchus. You can also see to the first third of the compartment of the alveoli, there is lymphatic structure here adjacent to the vascular arterial component or capillary component. And down here we have the pleura, and note the connection of the pleura. It's lymphatic vessels connecting with these interlobular lymph vessels, connecting back up to be brought up and deposited into the venous angles. So this mechanism of the velocity phenomena is occurring inside the lung in order to support this aspect of the alveoli that does not have any direct lymphatic components. And this is one of the few areas in the body where the lymphatic system does not reach into. There are other areas as well, which I'll cover in future presentations, but not many, only a few. More information on that cross-flow phenomena supporting the alveoli aspect of the lung. There is a recent discovery of microvascular fluid mechanical model of lymph flow of the lungs in regard to pulmonary edema. Obviously that edema is occurring when this cross-flow phenomena breaks down or the system is overwhelmed with toxicity or bacteria. Alveolar edema fluid is rich in proteins that have passed through a limited barrier and includes remnants of hidden inflammation. Biodirectional flow is reliant on the interstitial tissue pressure influencing alveolar and capillary membranes. There are no lymph capillaries located at the level of the alveoli. There is, however, interstitial fluid that flows from the alveolar septa into the nearest subpleural or peribronchial lymph vessels and connective tissues. The alveolar macrophages will follow the same path as the lymph, and as they are laden with phagocytized material such as bacteria, dust, or soup particles. Additionally, inside the bronchia, we have a mucosa. The right bronchial artery comes from a branch of the third posterior intercostal artery. The left has one upper and one lower bronchial artery that starts separately at the aorta. The arteries make their way into the bronchial tree to support a mucosal plexus inside the capillary plexus located in the air passages. The MALT, or mucosal associated lymphoid tissue, is a gathering place for the small T lymphocytes that serve as an immune response in the epithelium. At this point, it changes its name to BALT, bronchial associated lymphoid tissue. There are many instances of lymph nodes in the bronchial lining, which also act as foci for the production of T cells and immunoglobulin from B cells. Looking at pulmonary nodes, lymphatic nodes, the intrapulmonary nodes are a large group of hilar nodes located at the hilus center. The pulmonary root nodes are located between the structural elements of the hilus, near the area where the bronchi and vessels branch. The interlobular fissures also contain isolated nodes that run along the pulmonary artery. The intrapulmonary nodes serve as the initial lymph stations of the lungs. From there, the lymphatic flow continues towards the extrapulmonary nodes. The pulmonary ligament has surrounding nodes, which are the only intrapulmonary nodes with vessels that empty directly into the thoracic duct. So here we have a case. Again, as I mentioned before, most ligaments in the body have lymphatic structures traveling through them. And in this case, we're talking about a direct connection to the thoracic duct from the lungs. But indirectly, there are several chains, nodal chains, from the mediastinum that would connect directly to the thoracic duct, as well as moving up towards the venous angles. In this image here, we have the image of the pulmonary nodes here trailing along the brachia, and it doesn't show you the lung here, but again, everything is just so connected. The only thing that changes, the name of the nodes change, but the connections remain the same as they're traveling, wrapping around solid structures and tubular structures and all through the body. This image has that pulmonary ligament lymph node that we're talking about right here, and it does connect directly to the thoracic duct, which is traveling deep in the body. But you can also see how that pulmonary lymph node would be connected to the juxta esophageal lymph nodes as well, that are above the diaphragm and connecting to each other. Looking at the intrapulmonary deep lymphatics, the intrapulmonary lymphatic system is contained within the structure of the lungs. The lymph vessels follow the structures participating in the fibrous septa, such as the bronchi, the veins, and arteries. The subpleural or superficial lymphatic system is contained in the connective tissue layer of the lungs. The deep vessels wrap around the bronchi and the lung vessels as they pass through the peribronchium to the hilar lymph nodes. The deep and superficial systems are connected via the branches of the veins and the interlobular septa. The deep interlobular lymphatic capillaries transfer lymph from the periarterial connective tissues. And of course, here's that image again of the intrapulmonary lymph vessels as I've described already. We have the phenomena, lymphatic flow phenomena occurring at the alveoli. We have the pleura and the lymphatic structures of the pleura. Interlobular lymph vessels accompanying the venous and arterial flow, and the lymphatics accompanying the bronchi. So this is the deeper lymphatic system of the lungs.
Taking a look at extrapulmonary lymphatics. The extrapulmonary lymphatic system nodes located at the hilum are the primary nodes receiving drainage from the lung collectors and pulmonary pleura. The superior and inferior tracheobronchial nodes, the pretracheal nodes, and the anterior mediastinal nodes are secondary stations. The tracheobronchial and anterior mediastinal nodes are the main drainage pathways terminating in the right and left venous angles, respectively. The right and left lungs are divided into upper, middle, and lower drainage sites. Lymphatic vessels from both lower lobes lead directly to the pulmonary ligament lymph nodes and travel to the bifurcation node or the thoracic duct. In addition, lymph can descend towards the abdominal aortic nodes via the retroesophageal nodes.
Looking again at the mediastinum without the heart and pericardium, got the thoracic duct coming up through the center, and then these are all associated tracheobronchial lymph nodes supporting the extrapulmonary lymphatics, and they are still connected to the mediastinal lymph nodes. We have a right anterior mediastinal lymph node here, and then there's lateral tracheal lymph nodes here, and these chains are all interconnected. These are very deep lymph nodes, but they still have connections to the superficial lymphatics, and you can also see how they're following along the arteries, the lymph node chain supporting along the arteries on each side. And again, you've got the pulmonary ligament lymph nodes here, which I showed previously. So you can see the web of deep lymph nodes that are supporting the extrapulmonary lymphatic system.
Lymph from the left upper lung and part of the middle territory of the left lung flows towards the left paratracheal and anterior mediastinal nodes terminating in the cervical portion of the thoracic duct. Lymph from the left lower lung takes a different path and drains into the bifurcation nodes towards the right side of the body, where along with the lymph from the entire right lung drains into the right venous angle. It seems none of the lymph in the right lung flows downwards towards the abdominal thoracic duct.
Taking a look at pleural lymphatics, there's a visceral pleura covering the lung fissures as well as the pulmonary surface. The parietal pleura lines the inside of the thoracic wall as well as much of the diaphragm. The diaphragm pleura is thin and tight and adheres to mediastinal pleura with its connections to the pericardium. The negative pressure in the chest cavity is created in the pleural space by the inward elastic recoil of the lung versus the outer pull of the chest wall. The cervical pleura is also known as the dome of the pleura. Mediastinal pleura is known as the structures between the lungs. The fine meshed pleural lymphatics plexus drains into the coarse meshed subpleural network. Lymph from the intercostal muscles drains into the subpleural network as well. That's an example of the superficial lymph drainage going to a deeper pleural network. Along the inferior margin of the ribs, there are collectors which originated in the subpleural network and follow the intercostal vessels and nerves. Lymph from the parietal pleura and some from the intercostal muscles flows towards the regional lymph nodes. Lymph from the anterior parietal pleura drains into the peristernal nodes. Posterior of the parietal pleura, drainage occurs via the intercostal nodes. The dome of the pleura extends to the second rib, and its efferent vessels leave through the upper aperture of the thorax to terminate in the supraclavicular or deep cervical lymph nodes. The middle territory of the second and fourth ribs
has lymph vessels that reach the axillary nodes via the chest wall. The lower territory of the fourth and sixth ribs follow the same drainage paths. This image allows us to see the lymphatic drainage of the pleura. This appears to be fairly superficial, except when you get to the deeper cervical lymph nodes here. These axillary lymph nodes are superficial. The sternal lymph nodes are going to be superficial as well, occurring in this area. Now, this is the top of the thoracic duct up here, but deeper, the thoracic duct is traveling roughly through the center. Visceral and parietal pleura. The lymphatic drainage of the visceral pleura moves towards the deep pulmonary plexus inside the interlobar spaces. Lymphatic drainage of the costovertebral pleura drains into the intercostal chain posteriorly and the internal thoracic chain anteriorly. Lymph from the diaphragmatic pleura drains into the retrosternal, mediastinal, and celiac axis nodes. The mediastinal and midline diaphragmatic pleura are innervated by the phrenic nerve. Irritation of the central diaphragmatic pleura can result in pain at the tip of the shoulder and the lower neck at the C3, C4 dermatomes. The microstructure of the pleura contains microvilli and some cilia on its surface. Nerves, blood, and lymph all travel inside the pleura. Moving on to the esophageal lymphatics. Lymph vessels of the esophagus are in the wall of its structure and form two communicating networks. The mucosal plexus covers the most area, and it consists of longitudinal oval meshes that are partly in the lamina propria and the submucosa. There is no clear dividing line between the upper mucosal plexus of the esophagus and the mucosal network of the pharynx. It is only at the level of the cardia where the mucosal network ceases to communicate with the lymphatics of the stomach. Above the bifurcation of the trachea, the upper two-thirds of the esophageal mucosal plexus drain in a cranial motion, while the lower third drains in a causal direction. Looking closer at the efferent lymph vessels and regional lymph nodes of the esophagus, keeping in mind that we do have a thoracic duct that's traveling down through the center and branching off at the top near the venous angles. We know that the upper third of the esophagus is draining up towards these drainage sites, and the lower two-thirds is draining down and making its way back towards the thoracic duct. We also have the bifurcation lymph node here, which is instrumental in supporting not just the esophagus but the trachea, the extrapulmonary lymphatics, and the pericardial lymphatics. Seems to be a real hub for collection there. And we have the pulmonary ligament lymph nodes here, which is important to note that all organs that have ligaments are going to have a lymph node inside, which speaks to the efficacy of perhaps using specific pumping techniques to support the organ and the associated lymphatics. And we also have a connection here. You can see that the inferior diaphragmatic lymph nodes and the lymph nodes come down and they do support the stomach. Now keep in mind that the lymph is going to be moving up in this direction above the diaphragm. And in presentation part 6, we're going to get into the stomach and epigastric area to look at what's happening below the diaphragm with the lymphatics. Looking at thoracic wall lymphatics, lymph from the deep tissues of the thoracic wall drains mostly to the intercostal, peristernal, and diaphragmatic lymph nodes. There's also a small number of lymph nodes situated behind the xiphoid process. Moving on to diaphragm lymphatics. Lymphatic drainage of the deeper tissues of the thoracic diaphragm wall occur via the diaphragmatic nodes closely following along all arterial branches. There are a small group of lymphatic nodes underneath the xiphoid process. Intercostal nodes will eventually drain into the abdominal confluence of the lymphatic trunks, which is located below the diaphragm at the entrance to the thoracic duct near the cisterna chyli. There are also lymph nodes at the point near where the phrenic nerve enters the diaphragm. Afferent lymphatic vessels on the right side of the diaphragm also drain the convex surface of the liver. There are also nodes at the posterior aspect of the crura. There are also lymphatics that primarily drain the muscles that attach to the ribs. And lymphatic vessels of the deep diaphragm lymphatic plexus anastomose with the nodes of the abdominal plexus.
Looking at this diagram of the diaphragm, we want to appreciate the size of the central tendon. It's my suspicion that this is possibly the strongest muscle in the body, given its short range of motion and the amount of muscle and tendon that is involved. Of course, we have the phrenic nerves, and we do know that there are some lymph nodes and lymphatic vessels that are supporting the phrenic nerves. We also know that as the aorta, with the aorta, there are lymph nodes that are following along in a chain above and below the diaphragm, in the connecting to the celiac plexus system below. Here we also have the lateral arcuate ligaments, which are often talked about in the osteopathic anatomy in terms of using direct techniques to try and influence the diaphragm or the junction of the thoracic spine with the lumbar spine. And again, if we're just looking at the connection of the diaphragm with the pericardium, we know that there are lymphatic vessels that are following along from the pericardium to the diaphragm. We've got lymph nodes that are positioned along the way. So you can see why the activity of the diaphragm and the whole mechanism providing that sort of muscular elastic foundation of the diaphragmatic pump will have some influence on the lymphatics that are supporting the diaphragm and the phrenic nerve as well. I've showed you some images of that, but it is good to see that in this image, that connection between the pericardium and the diaphragm. So the important considerations here is that relationship of the diaphragm and the pericardium and the liver and the stomach underneath. Liver and the stomach are not in this particular image. So we have movement of lymph that is supposed to be coming up through the thoracic duct on the deeper level, but we also have lymph. Some of the lymph above the diaphragm will find its way back below the diaphragm on both sides, moving back towards the center to make its way back into the thoracic duct. So it's critical to have the right tone and position of the diaphragm and its adjacent organs in order to allow for proper drainage. If you end up noticing the edema collecting in the supraclavicular space or in the axillary space or in the arms, then you can surmise that there's something going on in that mediastinum that's not allowing the drainage to properly move its way to its terminus point, and likely it's going to have to do with those pressure gradients. So the tone of the diaphragm and the tensegrity of the diaphragm affects its position. That's going to affect what happens above and below it.
So it's not always a local issue where it's enough to address axillary edema by treating the axilla. I think we have to continue thinking about that central chain mechanism, clearing a path for lymphatic flow, rather than moving the lymph specifically, as you might do in manual lymphatic drainage,
which is proven to be quite effective. The challenge comes when the lymph comes back 24 or 48 hours later. It collects in the same areas. And it's collecting in the areas because it's not able to be that, the metabolism is not able to mitigate that extra or that bulk flow of lymphatic fluid. And the interstitial tissues are not able to fulfill their role in supporting the proper maintenance of the lymph. So when you affect the pressure gradients in the mediastinum, that affects the individual lymph nodes. That means there's more lymph left over, and then the body will store it in the areas that it finds the easiest. And that can happen in the lower extremity or in the upper extremity as well. Might explain why people with lymphatic issues will wake up feeling puffy. Their face will be puffy, their arms will be puffy. Once they get moving, things feel easier. The lymph drains a little bit, and that's because when we're laying in bed, again, any of the pressure gradient imbalances in the body will have an impact on how the body is managing or storing lymphatic fluid. The longer it stores it, the more likely we start to look at a higher toxicity level, because this is affecting the detoxification pathways. The longer that persists, the more likely the terrain will trend towards a degenerative tissue issue, or starting to get into the itis family of having chronic infections. And then if it's left unabated for long enough, then we can look at more cynical diseases presenting themselves in areas or lymph nodes that are easily overwhelmed. Coming back and again looking at the mediastinum, the deeper lymph nodes. In cases where you may have some cynical disease processes occurring at specific nodes, it's important to consider that the direction of lymph is biodirectional. We have some going towards the thoracic duct, some will go superficially, depending on what's going on in the pressure gradients in the area. Now, this doesn't have the pericardium involved because it's removed, but you can see the pumping of the pericardium would allow for movement of lymph to move wherever it needs to in order to achieve the goal of detoxifying the area. If you have areas that have an imbalance in pressure gradient or a density or tensegrity issues, then that lymph is going to have a harder time moving, which would explain why you might get lymph nodes that are overwhelmed, at which point the body will either create a cyst around it to try and help mitigate the toxicity, or the metastatic aspect will kick in where it will try and move the toxicity to other lymph nodes in the chain, because that's how the lymph is designed. One node can't do it all. It needs the support of the other nodes. So it's questionable whether it's a veracity of the cynical diseases attacking the system, or whether it's the natural movement of lymph that is merely just trying to continue moving the toxicity from node to node in order to try and mitigate it, so that it doesn't stay in one place and become a real problem for the body. The longer it stays in one place, you get the degenerative issues and associated pain that comes with that toxicity. In this instance, again, it'd be easy to see where we have the diaphragm on the bottom here, then we have the pericardium in the center here, and then you've got your venous angles here in the top of the thoracic duct as it comes up through the bottom, branching off. Easy to see how lymph can get trapped in this area. If we have a problem
with pressure gradients between the diaphragm, the pericardium, the aortic arch. All these structures will create a type of chaos in the lymphatic system, and the body will be, I suppose that's why the chains are organized in the way that they are, is to ensure that there's always an exit point for the lymph, whether it's deeper towards the thoracic duct or more superficial towards axillary lymphatics. We also know the lymph will move tendencies to move up towards the venous angles, but also deep towards the thoracic duct and also down below the diaphragm. This is likely to accommodate us in all our various activities, including sleep and things that are more cardiovascular in origin. Looking at the diaphragmatic pleural lymphatics, the mediastinal and midline diaphragmatic pleura are innervated by the phrenic nerve. Irritation of the central diaphragmatic pleura can result in pain at the tip of the shoulder and the lower neck at the C3, C4 dermatomes. That's going to occur on the left side of the body, typically. The microstructure of the pleura contains microvilli and some cilia on its surface. Nerves, blood, and lymph all travel inside the pleura. The serosal layer attaches to various structures of the lung except for the hilum. The lung contains partitions created by the connective tissues as they form many lobules, which are small polyhedral masses of tissue. The lobules receive a lobular bronchiole and, more importantly, the terminal branches of the arterioles, venules, nerves, and finally the lymphatic structures. Looking at the deeper lymphatics of the diaphragm, there's also continuity between the costal and mediastinal pleura with the thoracic plexus. The junction of the cartilage and the seventh rib is the location of the anterior diaphragmatic nodes. Deeper nodes exist on the esophagus posterior to the seventh rib at the sternum. And deeper still, there are nodes around the aorta as it exits the thorax. The abdominal plexus anastomoses with the hepatic lymphatics.
Last part of the presentation, we'll look at the thoracic duct and the cisterna chyli. Thoracic duct is the largest lymph trunk, and it conducts lymph from the lower half of the body. The gastrointestinal trunk and paired lumbar trunks act as the root of the thoracic duct. The cisterna chyli receives lymph from the efferent collectors of the superior mesenteric lymph nodes, which are formed by the meeting of the gastrointestinal trunk, gastric, hepatic, and pancreatico-splenic trunks. Typically, 80% of people have a cisterna chyli of some type. The thoracic duct can be divided into three segments named abdominal, thoracic, and cervical. When we look at the thoracic duct, the entrance to the thoracic duct, also known as the lower abdominal confluence of lymphatics, down here, superior to the cisterna chyli, which is right down here. Effectively, we have lymph the majority of lymph being collected in the below the diaphragm in the lower extremity, is all moving and trying to culminate at the entrance of this confluence. And some of it will use lymphatic territorial or superficial lymphatics to also travel up into more superficial lymphatics, including up into the axilla. And keeping in mind that the deeper lymphatics in the mediastinum also do connect towards the thoracic duct. So this is not the only area down here where lymph is entering. Lymph is also entering along the lines here, and basically anywhere of the thoracic duct there's lymphatic connections that are connecting to the central structure. And this duct has the capacity to dilate depending on what's going on. So once the aorta or the vena cava dilate, based on the activities we're doing, the thoracic duct has that capacity as well. But also, if the pressure gradients in the mediastinum are out of balance
then that will have an effect on the thoracic duct and its ability to move the lymph up to the terminal points. Now, it's also the entrance to the thoracic duct around the cisterna chyli. Because we have this diaphragm and we have the pressure gradients, negative pressure above and positive pressure below the diaphragm, any alterations or poor positioning of that diaphragm will influence the capacity for that lymph to move up. So what happens is it will collect in the lower abdominal area or in the pelvic area or in the legs, and it won't move as effectively, so the body will store it. The three portions of the thoracic duct. The abdominal thoracic duct is in the retroperitoneal region behind the right side of the aorta and is covered by the right medial crux of the diaphragm. Generally, the thoracic duct enters the thoracic cavity through the aortic hiatus. Lower portions of the thoracic duct is overlain by the esophagus, and it ascends between the azygos vein and the aorta. It is also covered by the pleura. The thoracic duct passes under the esophagus and the aortic arch. It ascends to the upper thoracic aperture at the near margin of the spine between the left subclavian artery and the esophagus. The thoracic duct receives afferent vessels from the intercostal and lower mediastinal lymph nodes. The cervical portion of the duct. The ascending portion of the cervical portion of the thoracic duct is located between the esophagus and the left subclavian artery. It is also covered by the vagus nerve and the carotid artery. The section of the arch that terminates at the left venous angle also crosses over the vertebral artery, phrenic nerve, cervical thoracic ganglia, and the thyrocervical trunk. So you can see the importance of that area and how lymphatics, poor lymphokinesis, potentially, or pressure gradients affecting the diameter of the thoracic duct could have an imposition on either the vertebral artery, the phrenic nerve, affecting cervical ganglia. So there are, vagus nerve, carotid artery. So there are various parts of the body where you might get symptoms. That's a very common area, lower neck pain, posterior scapular pain, these types of common muscular discomforts that we may not resolve with just cervical adjustments or myofascial techniques, etc., etc. You may be looking at an underlying issue with the lymphatic system. And if another way to determine that would be if you're looking at edema. So if we go back to looking at edema as a potential indicator of a osteopathic lesion, then it's important to consider that when the lymphatic system is congested, you have lymphostasis, you're going to get a triggering of potential surrounding structures such as nerves and also chemoreceptors. In many cases, the arch is also covered by the internal jugular vein. The terminal portion of the thoracic duct is generally a single tract, but it may divide into 2 to 3 branches and the occasional intercalated lymph nodes. The constant pulsation of the aorta assists in lymphatic movement under crossing of the aortic arch and the aortic hiatus. So again, as I've mentioned, we need to have some considerations if that if the aorta is affected in terms of its pressure, then that's going to have an effect on the lymphatic movement, including at the aortic arch. Once again, we have this image, and so anything that's affecting the pressure around the aorta, and we're not even including the pericardium in this, we're going to have some impacts on the diameter of the thoracic duct and its ability to receive lymph anywhere along its pathway, including below the diaphragm. So that's why coming back to the vascular tree is a critical component
understanding how the best way to get lymphatic movement is to restore the full potential of the vascular tree in any part of the body, but in particular with the mediastinum. So again, we're looking at the thoracic duct, and there are going to be some variations depending on the person. Embryologically, we actually have two of them at some point, and it merges into one as it sort of crosses over from the right side of the body over to the left in the mediastinum. But it's important to consider, these are deep lymphatic structures, lymph nodes and lymph vessels, and you can see that there are indeed connections that are going towards the thoracic duct as well. And in some cases you get a duplication of the upper part of the thoracic duct. And again, another view of the thoracic duct and also the associated lymph nodes, the juxtaesophageal and juxtavertebral lymph nodes that are also surrounding the aorta, but they're also connecting to the thoracic duct as well. And then we have again this pulmonary root, the bifurcation lymph nodes in the center that I spoke about earlier. And obviously your lateral tracheal chain up top and axillary lymph nodes over here that are more superficial. But you can see the complexity and the importance of managing lymphokinesis in making sure there's distinction between organs and optimal pressure gradients for the vascular tree, for the vascular system throughout the body, because its implications on creating tissue resistance and flow resistance if that is not the case. So just finishing up with some clinical applications around mechanical principles. We know that structure governs function. We want to reduce mechanical disadvantages that contribute to hidden inflammation and lymphostasis resulting from the mechanical disadvantages. Restore optimal pressure gradients and blood flow to allow for ideal lymphokinesis. Address the tone and position of the thoracic diaphragm. Address the tone of the pleural domes, which act as diaphragms given their composition of tissue. Restore optimal organ shape, size, tone, and position by removing densities, tensegrity, imbalances within and around the organs of the mediastinum. And remove the resistance in the connective tissue system that limits lymphokinesis and detoxification pathways, and in most cases that means following the intelligence of the connective tissue system to restore its local, regional, or global vascular flow. Some metabolic principles, lifestyle choices related to your personal pathology. You want to look at updated blood panel for a view of relative markers that limit resiliency and contribute to inflammatory scenarios. You might want to see if you have fatty liver, which will have an impact on the profound impact on the lymphatic system. We'll go into more detail in the next presentation if you want to look at that. We're going to look at insulin resistance, metabolic dysfunction in general, and hormonal imbalances, anything that's going to affect the detoxification component of the body. We want to look at healing the gut to restore optimal microbiome composition. Sleep hygiene is a critical component to recovery. Exercise or increased movement habits. Hydration is critical. And honorary mention to connection with community, having self-purpose, and cultivating meaning in your life. That concludes this presentation. Hope you enjoyed it. References are to follow. Thank you.